if you've got a thin biotype, which is a couple of millimeters thick, you can do all the platform switching you want, you can do all the fancy stuff that you want, that bone is not going to be stable. Hi everybody, it's your host Pav Kera again. Welcome back to the Dental Implant Podcast. You may see I'm in a different location, the lighting's different, my camera's not quite as great, and that's because I'm actually recording from work. I don't have my really nice webcam with me today, so I'm just using the inbuilt camera on my laptop. But I know that you guys are not here to look at this. No, well, let's face it, pretty good looking face, right? you guys are here. You guys are here for information. So I thought I didn't get a chance to record one this weekend. I thought I would record one now and get it uploaded as soon as I can for you. So just before we start, just to let you know, next Monday I am recording with Kevin Rose, and we are going to be going over patient communication. A real bugbear that I have is when I hear dentists talking to their patients and they're saying, drilling into bone, screw, and using all these technical terms and really putting patients off. So if you want to learn how to speak to patients in a patient-friendly manner, Kevin is absolutely superb with this type of stuff, so I can't wait to start recording with him. Again, today is going to be a slightly shorter podcast, although I'm fully aware that every time that I say that, I still rack up best part of 20-30 minutes. Let's crack on. What are we talking about today? Let's cover zero bone loss concepts. For those of you who don't know about this, I would highly recommend Tomas Linkevicius' textbook and reading his papers, critically reading his papers, critically reading his textbook. And it was in I did actually recommend his textbook in a podcast previously when I was talking about how to, where basically to start. And I did loads of textbook recommendations. Now, I want to say that this is my interpretation of Professor Thomas's data. I've added a few bits. I don't agree with 100%, but it's kind of like it's 90% agreeable with the stuff that he discusses basically. So it's not 100%. If you want to know 100%, you need to read his textbooks, and I may even reach out to him and see if he wants to do a podcast so we can go into this in more detail. Because today I'm going to be giving you an overview. Okay, so zero bone loss concept is exactly as it sounds. The aim is to try to have zero bone loss around the neck of the implants. Full stop. That's it. You don't want to see any bone loss. What I like about Prof. Linkevicius' work is he actually has some very good data, and he's got loads of case studies where he's getting very, very stable crestal bone. He's a great surgeon. It's just lovely to see, basically. So let's look at the surgical components to start with. So the surgical components are: you need 2 to 4 millimeters of bone around your implant for it to be stable long term. I know it's not always possible. I know that sometimes you need to graft. I know sometimes the patient doesn't want to graft. I know sometimes you can use osseodensification to expand. You can use hand instruments to manipulate the bone. But what you're gunning for is that 2 to 4 millimeters of bone around the implant, which is a lot. And it was actually Murley and his team who actually showed that if you want stable bone, particularly in the aesthetic zone around an implant, that 2 to 4 millimeters is actually really quite important. Okay. Next one, soft tissue thickness. You need good soft tissue thickness, 3.5 to 4 millimeters of keratinized gingiva thickness, height, vertical height around the implants. If you've got a thin biotype, which is a couple of millimeters thick, you can do all the platform switching you want, you can do all the fancy stuff that you want, that bone is not going to be stable. So the second component is you need enough vertical soft tissue height. Now, there's a number of ways of doing that. You can graft using autogenous, you can graft using mucoderm, which I quite like because it's such a simple way of doing things. You can use tenting techniques, and there's lots of different ways of doing it. Now, conversely, you don't want it to be too thick either. So if your soft tissue starts to become 5 millimeters thick, you run the risk of right at the base where the neck of that implant is, that the bacteria, the oral flora will actually change, become more anaerobic and less implant friendly, basically. Okay. Point number 3, the implant design itself. Tomas is very much a fan of Morse taper connections, but as Bill and I discussed in the previous podcast, it's down to how you do it. You need to understand your connections. And Tomas has used different types of connections and shown very stable results. Okay, the deep, steep internal connection, as we discussed last time, that gives that cold weld. It gives very stable results. Okay. Now, what I didn't go into too much detail last time because I was very conscious that we were starting to run out of time, is how to use external hex. Okay, you can get stable bone and you can get a stable joint with an external hex. It comes down to how you do it. I'm going to cover that in a separate podcast probably, because it's quite a few tips and tricks I'll give you. Now, the reason why I use external hex is because I do so much full arch work. We use southern implants, and it's that coaxis, that internal angle correction, which saves me so much grief and doesn't chew into my prosthetic space. And with the DC connection they do have other connections as well. The maximum you can go with an angle correction is 12 degrees. Quite often when I'm doing full arch is I need a 24 or 36 degree angle correction, which is only available in the external hex. And that purely comes down to the mechanics behind doing that internal angle correction within the head of the implant. So it's just be aware that anybody turning around and says to you external hex is not a stable joint, is they're looking at old data. It can be a very, very stable joint. The other thing that I'm very much a fan of as well, as you know, is a machined neck on the implant. Now, a machined neck, if it's conditioned before it goes into place. If it's not conditioned, different ball game. For those of you who want to know more, superosseointegration, listen to the podcast, okay? A lot of people listen to other podcasts about how to progress your implant career, and you haven't listened, or not as many people have listened to the ones on occlusion and superosseointegration. There's a little bit of a hint. If you want to progress your career, you may want to learn a little bit more about the occlusion stuff and superosseointegration. Just a little tip. So, yeah. The other thing that you can do is, depending on the connection type, you can countersink and sink the implant lower to get a channel of soft tissue which comes up. And that's what Ankylos and Bicon are actually really, really good at, and anything with a genuine Morse taper. Now, be aware, a lot of implant companies will tell you they've got a Morse taper, but when you say to them, what's the actual angle within the connection? Oh, it's 12 degrees. That's not Morse taper then. That's just an internal hex. So you've got to be really careful and understand your data and understand what implant system it is that you're using. Okay. So the surgical points that we've covered: bone volume 2 to 4 millimeters, soft tissue vertical thickness, it needs to be 3 to 4 millimeters. Don't go too thick. Implant design, we talked about Morse taper if you want to bury it deep. We talked about machined neck if you condition it before it goes into place. Okay, right. So prosthetics, screw retained versus cement retained. Okay, this one's really simple. Go screw retained wherever possible. Okay. The emergence profile needs to be natural, okay? Now, look at the VPI cervico system. I am going to hopefully be doing a podcast with Minas, who's been using this quite a lot. You basically make customized healing abutment, and it is beautiful. Oh, my word. It's the results that you get is just incredible, okay? What you don't want is you don't want a thin implant and then a sudden, like what they call tomato on a stick, lollipop on a stick, whatever it is. That sudden profile is not good because it alters the bacteria towards the neck of the implant to anaerobic type. So your emergence profile will actually alter the flora around the implant. That's why the emergence profile is really critical. Okay. You need to understand whatever you're placing subgingivally, I want highly polished zirconia. I don't want it stained. I don't want it glazed. So below the gum line, I want super, super, super high polished zirconia. Okay. The reason for that is you will actually get muco integration. The soft tissue will actually integrate to the zirconia itself. And what you don't want is you don't want the body of it, most of it, to be titanium, and then like right towards the neck for it to be transitioned into zirconia. So this is a different type. So you either use a TI base or a custom base, but have it the titanium really quite narrow, so as much zirconia is in contact with the soft tissue as physically possible. Okay. Supragingival restorative materials, yeah, by all means you can stain them, glaze them, do whatever you want to do. Just don't have that stain, that glaze going below the soft tissue line. So if you're working in the posterior, if you have to go cement retained, you can go custom hybrid zirconia abutment and actually keep the margins 1 millimeter supragingival. And then when you're cementing a crown, you've got a supragingival margin. Guess what? All of a sudden, you don't have cement excess. Now, the whole thing of using floss to clean cement, using dummy abutment first, and then cleaning off the excess, and then putting it in place, or using rubber dam around the neck, doesn't work. You will always, always, always have cement remnants. So if you have to go cement retain, you have to make sure that your margins are no more than 0.2 millimeters subgingival, ideally equigingival. So if you're working in the anterior, if I'm doing some work in the anterior and I have to go cement retain, I tell my lab that margin needs to be 0.1 millimeters subgingival at the very most. Okay, so zero bone loss concept protocols for the lab. Okay, so you want a really super high polished finish to the zirconia. Without that super high polish, or if you glaze it, the soft tissue won't attach to it. It just won't. Okay. Now there's a few bits here with regards to cleaning the prosthesis before we go into place. I've got a colleague who's done a lot of research into this, and there are certain protocols, and I think that's going to be a separate podcast, so I won't go into that too much, okay? One of the cements for, if your lab's putting everything together, is GSEM Link Ace, and it's just been shown to have super high bond strengths. So again, when the lab's luting everything together, you're going to have fewer problems, okay? Now, remember all the stuff that I talked about with Riaz with regards to occlusion. That is really important. I've implemented all of that already with regards to the 20 microns, 40 microns, etc., etc. It's really important. Please, please, please do not use replica components. Use original components. Get brand new prosthetic screws. Get the lab to use brand new lab components every single time, because when you're screwing and unscrewing things, the preload in the screw changes. So if your lab's been using a screw, you get that back, you use that same screw, you don't have the same preload. You are on a losing battle right from day one. Okay, so the reason why I've not gone into the lab protocol too much is because I want to do a separate podcast onto that. Okay, now what's really important, you guys understand that when you start to do bridges on implants, attaining a passive fit is really, really important. And one of the things that Prof Linkevicius goes into is using indexed and non-indexed pickups and abutments. This is really good because this is one of the reasons why I think his book's good. It'll help you understand and improve the passive fit of your prosthetics. So if you've not read his book or you've not started to read it, again, it is something that I highly recommend, not just only because it goes into the surgical aspect and it goes into the restorative aspect. He'll help you understand how different connection types and how different, not only connection types, but different transfer types, index versus non-indexed, how to use those when it comes to implant bridge work. So what you don't want to do is you don't want to use index for everything, because then you're going to run into passivity issues. So it'll get you thinking. So it is a very, very good textbook. So what you will find is not only will you have really nice soft tissue healing around it, but when you use these protocols, I've noticed on my recalls that you get you get not only health, as I said, healthy tissue, you actually get muco integration. So the pocket charting around these implant crowns once they're fully healed. You're talking a couple of millimeters, and that, for me, that's just fantastic. You've got a restorative material which plaque won't adhere to. You've got a restorative material which the soft tissue will adhere to. I think we are now beyond osseointegration, and we need to be looking at muco integration as well in order to push the care of our patients forward. So historically, I have done PFM. I've switched away from PFM for quite some time. I do have reservations with regards to full arch and long bridges in zirconia for a number of reasons, but there's a number of ways around that. But you need to look at the data and understand the data and start making up your own mind. Now, I can give you a little bit of information. I can't learn this stuff for you. So thank you very much, guys. As I know that this has been, and it's been deliberately a little bit shorter, because I just wanted to go over the synopsis of zero bone loss concepts. And what I will do is I will reach out to Prof Linkevicius. Please do check out. And I don't have any affiliation, by the way. I'm not getting any type of kickback or anything. It's just I think the data he's got is very, very good, and it's certainly worth looking at. Look at his website, reach out to him, read his papers. But as with everything, it doesn't matter how good I tell you the papers are, you still have to read it with critical appraisal tools and come to your own decisions, because the conclusions you come to may be different to the conclusions that I come to. So, and this is one of the nice things that, is we all have our own interpretation of the data. We need to find what works in our hands, basically. So thank you very much for joining in again, guys. And it would mean the world to me if you could invite your friends to listen to the podcast and just share. Just share the podcast so more people listen to it. That would be hugely appreciated. And I shall speak to you soon. Bye.